Good morning, everyone. It's on the hour. We're gonna get going, and I see folks from all over coming, even super early morning in Micronesia. Hi, you guys. and I'm Lisa Chen from the Curry Center, and I'm here with my co-host, another Lisa. Go ahead.
I'm Lisa Armitage from the Heartland National TB Center.
Yeah. So we are just so grateful that so many people have signed up to join us today. I think we're bringing what we feel like is an important topic because just face it, it's been an overwhelming year. You all have been so busy with both TV and COVID, and but we realize it's been an overwhelming year as well as we grapple with the increased visibility and really reckoning that we've all had with both the inequities and the social injustice that we see in our systems, in our communities. And so we just thought that it was high time that we bring this conversation, really opening up the dialogue with our TV community. And that's what we're hoping to do today with kind of all the fabulous speakers that we have. I know, Lisa, you had some thoughts too as we started.
Yes, I mean, there's the question of, there are other minority groups that are having, that are also, having problems with equity. And, I guess early on, the question arose to us, why did we decide to highlight the African American community? And I think that's a fair question because there's inequity in many different places. But I think lumping all of them together just kind of minimizes the struggles that individuals have. So, we chose to pick kind of one area that, to focus on, that we as a public health community, overwhelmingly, we are caring. We're really focused on the care of our community, the care of our patients. And I just think, focusing on some things that we can do just one group at a time will help us get there.
All right. Well, thanks, Lisa, for that. And just to note before we really get going is that for any of you who prefer having some closed captioning, I think we'll have Jeannie put that closed caption option up for you. But you should soon see a button, at the bottom of your screen that allows closed captioning. Go ahead and use that if you prefer having some closed captioning options. You see it right now. It says live transcript. So go ahead and use that if you prefer that. And Lisa, I'll let you get going with the start.
Okay. I have Jeannie pull up my slides. So the first question we asked, so tuberculosis in African Americans in the US, are we making any progress? Next slide. You'll see a series of slides here looking at tuberculosis in the US from 1993 to 2004. These are weighted from a talk that Ken Castro gave when he was over the Division of TB Elimination at the CDC. And when it was found that there seemed to be a disproportionately large number of cases of TB, that were focused in the African American community. And so this is looking at a trend, a 10-year trend from, before he gave the slide in 2006. And almost half of the cases of TB in the US and US born individuals were found in the African American community. Next slide. So if you look at the reported cases by race and ethnicity, this is 2006. So he had done the 10-year trend prior. And when he gave the talk, you see that African Americans, despite the fact that there were about 13% of the population, were 27% of cases. And next slide. When you look at the same place we are here in 2019, the number's gone down a little bit from 27% down to 20%. In the Caucasian community, it went from 17% down to 11%. But when you look at the Asian population, there's a significant increase in the numbers. It's where you see a lot of the growth. But next slide. when you divide out by US born and non-US born individuals, and I would say, if you're talking about a next place that we need to be focusing, the next place would be looking at our Asian populations. Non-US born, 48% of the cases in that group demographic alone are Asian. But when you look at US born individuals, African Americans, despite again 13% of the population, have the highest percent of the highest number of cases of TB in the US. At 36% of the cases are African American. Next slide. And this is just a graphic. When you compare the non-US born individuals to US born individuals, African Americans are very highly weighted in the US born population. So again, about 3 times what we represent in demographics of individuals. Next slide. So this was a very interesting, this was the first slide when I talked to Lisa about doing this. This was the first slide I thought of. And you look at just the trend over time, there is a gap between, the Black individuals and white individuals. And this is just carried over, over the 10-year period. But there's a gap between where I'm going to pick up on the next slide from 2004 to 2010. But next slide. What you see is still that gap. We've gone from 2010 to 2019, and there is still a significant gap there. Next slide. When you look at the pediatric population, so I will say that in every age group except greater than 65. If you look at the greater than 65 age group, the absolute number of cases is higher in Caucasian individuals than Blacks, but in every single age group, it is a higher number. And if you look at pediatric cases, these are children from 0 to 14 years of age. For all races, there were 293 cases in 2019, I'm sorry. And 72 of them were Black and 21 of them were white. So again, all the way down to the children. So we're getting transmission in the African American community, in addition to, the age representation as individuals get older. Next slide. So we don't have this data broken down by race in the current guidance, but this is from the same set of slides that Kim Castro presented in 2006. And I thought, with what we're doing as a nation, it seems like there's a lot of the same data in here. So if you look at whether individuals were more likely to be unemployed, very similar. Next slide. Whether they're likely to be homeless, maybe, some, separation and a little bit more representation in Black individuals, but not really, pretty close to the same. Next slide. You look at a history of substance abuse. Now you see that there's a little bit slight increase in likelihood that an individual will, that has a substance abuse problem and TB would be African American. And the next slide. Really, percent of persons with TB diagnosed in a correctional facility, much higher representation among Black individuals. And so the other things looked at, just, because the question arises, is there something different? Diabetics, HIV infection, non-HIV immunosuppressants, TNF alpha blockers, these were all divided up in the 2019 data, and they were percentage-wise almost equivalent between Black and white individuals. So it doesn't seem like it's anything medically that is different. Next slide. But I thought this rang probably the best and in the public health arena. When you look at overall completion rate and then completion rate with a year across every race, if you get the individuals into your office, it seems like they're at least getting to completion of care and curing. Next slide. So again, the question is, are we making progress? And so on some levels, yes, because all of the numbers are going down, but all of the numbers are not going down the same for everyone. So they're going down kind of, in a manner that just still shows disproportionate representation within several of the communities. Next slide. So I pulled a quote from our new CDC director, Rochelle Walensky. And, her point is she is declaring that racism is a serious public health threat. And we know that health inequity is a public health, issue. So when we have some inequities and we have disproportionate representation of burdensome diseases in certain populations, we as a public health group are kind of charged to get in and to take care of the members of our population. And so I'm going to hand back off to Lisa, and she's going to introduce the next section of our webinar, and talking about affirming some of our commitment to making our public health a better, to making the health of our public better.
Great. Thanks so much, Lisa. So it's really with great pleasure I can introduce our next speaker, Dr. Lamisha Hill. She's a psychologist, a diversity expert, an educator here at the University of California, San Francisco. She's the director of the Multicultural Affairs for the Office of Diversity and Outreach, and she oversees the Multicultural Resource Center that focuses on celebrating diversity, social injustice initiatives, and mentorship for our historically underrepresented learners. She leads educational activities on diversity for the university. And so it was really wonderful that she jumped right in a year ago. I think when I know my teammates at the Curry Center, we were struggling with what was happening in the news and what we were feeling both in our professional and in our personal lives. And so she was gracious enough to join in and do a talk specifically for the Curry Center and for our pulmonary division. And so I'm just so pleased to be able to share Lamisha with you all today. So take it away, Lamisha.
Thank you so much. Much appreciation for the invitation, and really to the now 220 plus members of your collective community who have dedicated their time, y'all's time, and your attention to this very important work and topic. So I'm going to share my slides so I stay on track, because otherwise I may go off on a rant. So thank you again. My name is Lamisha, and I do use she, her pronouns, and much appreciation for the introduction. I am a licensed psychologist by trade, and so that really influences the lens and the narrative in which I approach this conversation. And so as we have been in a particularly both challenging and very impactful year, I really wanted to think about how best do we sort of frame the things that we are talking about and discussing so that it is accessible to everyone. So really that is my hope. So before we start, I really want to begin with the land recognition and giving honor to the Ramaytush Ohlone people, who are the original caretakers of the land we commonly know as the San Francisco Bay Area Peninsula. We want to pay our respects to the Ohlone elders, past, present, and future, who were and are the stewards of this land and this place that they know as their home. And we're proud to continue this tradition of growing as a community and look forward to supporting and strengthening our ties with our Indigenous communities. I really want to invite for you all, wherever you are in the world, to really take the time to learn and know who are the original caretakers of the land that you call your home. What are the Indigenous communities that have really nurtured and taken care of the earth and the ground that gives us all the ability to access it today? And before we know as it is today, it used to be something else. And it's a really important process in equity and inclusion work. So today I'm here to discuss some of the national events surrounding anti-Black racism, and also want to provide some themes specifically around diversity, identity, and race. I want to close with a few opportunities and strategies for allyship and furthering the commitment in this work. Really, the decision to center this webinar series on improving the care for African American patients could not have been more timely. And really to consider the past year challenging is an understatement. we have been embedded in what feels like an ongoing crisis of equity and justice. And as individuals, we are simultaneously having a unique experience, but a collective experience as well. And so I want to take a moment to invite for folks to really come in and participate a little bit with us. And if you could just take a moment to maybe just write 1 or 2 words in the chat of how you have been most impacted by the events over the last year. And if you go ahead and just start putting those things in the chat, maybe it's health concerns for yourself or for family members related to COVID-19, perhaps the ability to care for loved ones, whether it's children, elders, neighbors, and others. Maybe you became a teacher overnight and you didn't know that was going to be part of your personal and professional duties. Maybe you are really powerfully touched by the rise in police violence and anti-Black racism, perhaps by the rise in anti-Asian violence and other forms of hate crimes impacting our API community. Perhaps it's the social isolation from friends and colleagues, whether that's working remotely or not being able to connect personally. Wellness and self-care, that may also include mental health. And we know that people have been really economically impacted. And there may be other themes that I didn't list here. Just curious, I want to take a little bit of a pulse, a little bit of an inventory of how you all have been most impacted. I'm going to take a peek at that chat. So apologies if you see any overlay on my screens or little blurbs and boxes. I'm just going to read out and reflect back a few themes so that I really understand. So duties around work, the division around race, general heartbreak, stress and sadness, isolation, police violence, social isolation, managing kids' education, and increase in working hours, the loss of a family member due to COVID, absolutely. And we're so sorry for your individual loss and the losses that other people have experienced. General fear and unknown, workload, self-care, all of those things, burnout, absolutely. All of it is deeply, deeply powerful. So we are in a moment right now. I want to ground us a little bit more formally, right? As providers and those who have shown up in healthcare, we know that health disparities are real, right? We have known that and we know it. But the impact of the infection and morbidity and mortality related to COVID-19, I think amplified what was well known in healthcare on a broader national and international scale. And so particularly the infection and death rates among historically underrepresented communities, including Native American and Indigenous communities in the country, API communities, African American communities, and Latinx communities. And so really what I want to affirm is that the loss of life is not just numbers on a screen. In particular communities, specifically for many Indigenous and Native communities, it actually connects to the loss of culture, the loss of language, the loss of history that will never be regained. And simultaneously, throughout this year, every single month and in the most recent weeks and days, it feels like every single day, we hear of another story of a tragedy, of a injustice that is particularly targeted towards African American, Black and Brown communities. And so whether that's Breonna Taylor, George Floyd, Ahmaud Arbery, Tony McDade, and now the names go on. And I really want to encourage you all. I know sometimes it can feel overwhelming, but to be in touch with those names, to take the time to learn the stories when we have the capacity and the heart space to be able to do so. And it doesn't mean that we have to interact with the trauma, but I do think it is important to acknowledge the humanity for those that are continuing to lose their lives at the intersection of anti-Black racism and police violence. And in parallel, right, we want to also acknowledge the rise in anti-Asian violence and hate crimes that has come along and the ways in which that really was intersecting with the way that people in positions of leadership were discussing the amplification of COVID-19 and rooting that in very racist and xenophobic perspectives. And so how people are showing up, right? I'm your psychologist, so I want to kind of come back to your heart, right? Really in grief and sadness. And we saw that in the chat. And thank you for those that were able to acknowledge that, just that overwhelming emotion, anxiety and uncertainty. But I do want to acknowledge that racial trauma is real. Racial trauma is real. And so there is a historical trauma that communities hold, whether that's based on their own lived experiences, their own identities. The lived trauma that people are embodying that oftentimes we don't talk about and we don't discuss. And so when the things happen in the news and the media, it is not just out there, it is actually happening to the people that are around you, your colleagues, your peers, the people and the patients and the families that you interact with in your healthcare settings. And so oftentimes that grief can show up and look differently. Maybe it looks like disengagement. Maybe it looks like a change in energy, but in so many ways that's individual, that's invisible. And because we work in healthcare and because we work in sort of the intersections of research and education, we are called at this moment to continue to show up. And our industries haven't really found a way to create a space and a buffer for us to be able to think about how do we best take care of ourselves and really connect and work with one another so that we can potentially call out when we need to take time for ourselves. And so what the power of this moment is again, yes, we are having an individual experience, and yet we are in that way emotionally available to be online to have a greater understanding of the power of this current moment. And so if we roll back the clock just a little bit to 2013, 2014, and the rise of the movement for Black lives, and really from many radical Black women who went online with the hashtag Black Lives Matter and started a national movement. Perhaps people didn't realize or quite understand, depending on where they were situated in the world or in their lived experience, that Black lives do in fact matter. And there was a first wave of trying to understand how when we amplify and say that Black lives matter, it is not within the absence of others. And so in this moment, right, there is a second iteration to really give recognition that there is something very, very powerful that is happening in targeted communities. And so now it is an opportunity to perhaps address the long-term issues of inequity and racism. But more powerfully than addressing some of the themes that are happening, and it's easy to sort of watch a newsreel or footage and talk about the injustices that are happening out there in the world. But in the intersections of healthcare, research, patient care, education, all of the things that we are embedded in our organizations and in our teams, these themes actually vibrate back towards us. So they're in inequities and long-term injustices that are happening in our organizations. And so it is an opportunity to actually pivot backwards and say, how can we think about not just the injustice that's happening out there, but how do we talk about it as it is showing up in our work? And so I really think about it as an opportunity to anchor our work in equity. So I want to go through just a couple of sort of high-level pieces related to diversity, equity, and inclusion. And I really think about it like a formula. That diversity in some part within our Western American culture, while it does encompass and incorporate all of the aspects of who we are, the multiple forms of the identities that we bring together, it will always sort of distill down to representation. And equity being a form of access, and inclusion being the opportunity to fully participate. And in an outcome value, it really is a perspective around belonging. And because my remarks are brief, I'm going to skip through a couple of slides because I want to come to this point that is, I think, particularly powerful, which is about understanding the social construct of race. And so I'm going to play a video for you all, and then wind down our remarks. And so just give me a thumbs up if you can hear the sound as I play this video.
You may think you know exactly what race you are, but how would you prove it if someone disagreed with you? The fact is, even though race drives a lot of social and political outcomes, race isn't real. One of the first people to attempt to categorize humans according to race was a German scientist around 1776. He came up with 5 different groups according to physical appearance and geographic origin of their ancestors. Americans of European descent eagerly bought into this type of thinking around the same time. Some historians have said the idea that there were different races helped them resolve the contradiction between a natural right to freedom and the fact of slavery. If whites were their own distinct category, then they could feel a lot better about denying freedom to people who they labeled black and decided were fundamentally different. But as political priorities change, definitions of race in America adjust right along with them. For example, if you were of Mexican birth or ancestry in the United States in 1929, you were considered white. Then the 1930 census changed that to non-white to limit immigration. Later, when the U.S. needed to increase its labor force during World War II, these people were switched back to white. And what it took to be black once varied so wildly throughout the country, from 1/4 to 1/16 to the infamous 1 drop of African ancestry, that people could actually change races just by crossing state lines. Then suddenly in 2000, the government decided that Americans could be more than one race and added a multiracial category to the census. This has left many Americans scratching their heads when it comes to selecting who they are. As many as 6.2% of census respondents selected some other race in a 2010 survey. The idea that someone might look one way and identify another way, or that they might be really hard to place in a racial category, is not new. This is why there was a public debate about whether MSNBC's Karen Finney could say she was black, or how we can't even agree on the racial label assigned to the President of the United States. Of course, many people feel their racial identity is very clear and very permanent, but the fact that some people have changed theirs and that no one can really argue with them shows how shaky the very idea of race is. This is all because there isn't a race chromosome in our DNA that people can point to. It simply doesn't exist. When the medical community links race to health outcomes, it's really just using race as a substitute for other factors, such as where your ancestors came from, or the experiences of people who may have been put in the same racial group as you. Dorothy Roberts explains that sickle cell anemia is a prime example of this. The disease is linked to areas with high rates of malaria, which include some parts of Europe and Asia in addition to Africa. It's not actually about race at all. This, of course, does not mean that the concept of race isn't hugely important in our lives. The racial categories to which we're assigned can determine real-life experiences, they can drive political outcomes, and they can even make the difference between life and death. But understanding that racial categories are made up can give us an important perspective on where racism came from in the first place.
All right. So
you may think
it does that. So I just want to amplify, in this current moment, that it's really important to really consistently remind ourselves that race is a social construct. And while it is powerfully impactful, the process of teaching and continuing to stratify people across phenotypic characteristics is not scientific and not always helpful. And in our efforts to move towards what I like to call DEI 2.0, we also have to be more brave in naming whiteness in the discussion of race. Because oftentimes we center this narrative on people of color in a way to perhaps amplify their lived experiences, or even perhaps in an attempt to acknowledge their resilience. But as we do this, we reinforce systems of the status quo, structures that are very, very problematic. And we have to be more fully able to engage in a thoughtful dialogue and a discussion that really has the ability to break down systems. And so I just want to acknowledge briefly the work of Robin DiAngelo and what is, I think, really, really powerful about sort of adopting this perspective on race and our inability to discuss race, because oftentimes it is seen as amplifying division and this idea of either calling and personalizing people as racist, right? And so Dr. DiAngelo says that the definition of racism framed in this good-bad binary is a root of white defensiveness. I would just say defensiveness broadly. It creates this sort of personalization and a difficulty in moving towards this conversation. And so in this definition that racism and racist is an individual, fundamentally disrupts our ability to examine the systems and the structures of racism. And so while there can be either interpersonal or individual demonstrations, we do have to understand that racism is in fact ecological in this way, right? If we know about the ecological model, it shows up everywhere across our systems. And so the invitation and the thought, sort of moving to Dr. Ibram X. Kendi to think about anti-racism, is really a process where we are examining how either our behaviors, our decisions, and our policies and our systems either support racial equity or reinforce traditional systems that actually support further racial division or further oppression for different communities. And so I do want to say, sort of in closing, right, that, as a diversity expert and a facilitator, I always want to utilize an ecological and intersectional lens. But I do think that it's important in this particular moment to amplify the legacy of anti-Black racism in our country and its exportation across the globe, the ways in which it's influenced racism for other Indigenous and people of color, and the ways in which we have seen a rise of oppression across other groups, right? So starting in one place historically, and then it coming up to really impact everything. And so I'm gonna stop there and be able to kind of come back sort of at the end with some strategies and ideas for change. So I'm gonna stop sharing my screen and I'm gonna pass it back over to, I believe, Lisa, one of the Lisas, who's gonna introduce the next speaker. Thank you so much.
All right. I mean, thank you so much for that. That is, a lot. It's a lot to think about, but we are at a very unique point, and these are all things that we need to consider. Want to introduce our. So it's Abe Tyrone Thomas, who's we call Ty, affectionately referred to as Ty. So Ty was a patient here in San Antonio at the TB hospital at the Texas Center for Infectious Diseases, and joined Heartland as what started off as a patient worker. And we rectified that quickly and snapped him up, and Ty has been a huge part of what we do here ever since. But he made a video. We asked, for him to share his experience as a patient and what it is to be on the receiving end of care. And so he's created a video for us to share with you today.
Before I begin, I would like to just say a few things. When I do my videos and I tell my story, it's never my intention to be rude or disrespectful to anyone. It's never my intention to throw anyone under the bus, to step on anyone's toes, or to paint anyone in a negative light. My position is to speak truth, not only about myself, but about things that took place before, during, and after my treatment with TB. The point of all of this that we're doing, I hope, is to bring light, bring awareness to things that just need to change. Because in the beginning of all of this, I had to deal with the stigma that surrounded tuberculosis. I believe that a lot of the misdiagnosis that I received from Baptist Hospital had a lot to do with, one, I'm African American. Two, I had no insurance at the time. And three, just an overall perception of me because of things that were going on in my life at that time. Verbally, I started seeing, that I was bothered by certain words that were being used. I really started to notice that when everything transitioned from hospital to health department, and just a certain use of the words like case and investigation would just make me feel some type of way. It made me feel like a criminal. And I understood the severity and the strictness of the rules. I understood that I was potentially a hazard to not only my family and friends, but even potentially essentially to the community. I understood that. I got that part. I couldn't get past the language. Case, investigation. You hear those words. I related to the first 48, the show. And again, it'll make you feel like a criminal. I believe in the beginning there was a partnership that was established between me and the person that I reported to at the health department that felt like it was more than just a patient-nurse type of situation, but more of a criminal probation officer type thing. The fact that she had to literally watch me take these pills, it did make me feel like a patient. There came a time in my treatment with my health department that the lady decided to take me off of the meds, and after that I did not go back. During that time, another one of the workers at the my health department paid me a visit to my residence, and she called that unexpected visit a retrieval attempt. And when I hear the words retrieval attempt, so I'm thinking my car is about to be repossessed or something like that. Retrieval. You're coming back to take back what was given to me. Retrieval. And it just didn't feel good hearing stuff like that all of the time, every day of the week. I'm calling home and my mom's like, the people call for you, they looking for you. When you're going through what I was going through with TB, stuff like that just made the whole experience worse. Stigma and body language. So there came a time where the director and the assistant director paid me a visit during my second stay at St. Elizabeth Hospital. This was back in January of 2020. And everything from the way that they walked into the room, they had on the same colors. They walked in cadence. They walked in, they stood against the wall, and it was this weird silence for like maybe a minute while we examined each other and decided who wanted to speak first. And right when I was about to say, what do you want? One of them began to speak, and they began to use words like, we've been looking for you, and had we not found you, we were going to begin the court order process. That made it feel like this was some sick version of good cop, bad cop. And again, I was feeling like a criminal. And I believe at one point I did ask them to leave the room, which they didn't, because they had a job to do. I was presented with two options at that time. Either come to San Antonio voluntarily or be court ordered to go. Here's that word again, court ordered. So naturally, I chose to go voluntarily because I'm already dealing with TB. Why would I want to add the court system into my life? When I came to TCID, that's where the angry black man developed. And no, I didn't come here angry. I came here confused. I went to TCID with a lot of unknowns. Very little explanation. The lack of explanation, the lack of being thoroughly told what was going to take place, that's what angered me. It came a point where the angry black man thing had already been established, and now one of the side effects from the TB medicine is I'm developing uveitis in my left eye, and I'm going blind at this particular point. This was around April. I'm going blind, I'm scared, and I'm still being labeled the angry black man. Every day that I decide to not have a smile on my face and not be positive and not just do what everybody was expecting me to do, which was just to don't worry, be happy, I was labeled the angry black man. And that pissed me off. And then the situation happened with one of the nurses attempting to give me the wrong dosage of medicine. I'm telling her this is the wrong dose, and she's telling me that I'm wrong. And then when she finally figures that she's not going to be able to continue to tell me that I'm wrong, that she attempted to place blame on my doctor, saying that she had changed the medicine. No, no, because one thing that my doctor made sure was anytime she made any type of changes, she either told me face to face, had another member of staff tell me, or she rang my phone. One of those three things happened. So she could not tell me that my doctor changed my dosage without letting me know. After a little bit of an exchange, I was like, look, I'm not taking it until you prove me wrong. Show me where it says I'm supposed to take this. So she went back into the nurse's station and she came back with the correct dose and jokingly said, oh, you're right, and just kind of passed it off as if this was some joke. So at this point, I'm upset, and I'm talking to another patient who happened to be in the lobby at that time, and I was like, this shit here is why I'm going blind in my eye. This. And she took offense to what I said, and she shoved my medicine in my hand, and she walked off. And she was talking, I'm guessing, about me, but in her native tongue. So I, at that point, got up and I followed her to the nurse's station. I did. And again, that's probably what I should not have done, but we were at that point. This whole situation could have been distinguished had she just paid attention to what I was saying. I know the medicine that I've been taking, and I know how me and my doctor communicate. But again, she was one of the ones that labeled me to be the angry black man. Now, in time, the angry black man thing changed over and it switched to me being the Prince of TCID. And that's only because I was not only verbal about stuff that I felt was wrong with me, I was verbal about stuff that was going on with the patients that I didn't understand, that I didn't approve of, that I didn't think was right. And so, yeah, they gave me that label. And at this time, yeah, I'm taking it all with a sense of pride because what you're not going to do is continue to mistreat us and think that it's okay. So it was a lot of things that I tried to bring to the attention of those who needed to know. Some things may have gotten swept under the rug, but I believe now that I'm in the position to speak and to be heard, those things are starting to come back to the light. Hopefully, this will bring light to those changes that need to be made. Patient care has to be the same. It cannot be biased because you're the nurse of a patient and you just happen to speak the same language. It can't be biased because you and that nurse and that patient are the same skin color. Every patient has to be treated the same way because at the end of the day, we are dealing with unknowns.
Okay, thanks so much, Ty. We're going to transition to a panel of individuals that are going to talk to you a little bit about some some ways to make positive change. And so I'm going to start, and then I will pass on to the next person, and we'll kind of work our way through the group. So I wanted to start, to address the individuals who I would say are lead. If you are the lead in your clinic, if you are the head nurse, if you are the physician, if you're the clinic manager, my thing is, at the top, it starts at the top. Set the tone in your clinic. Little remarks about patients, people get upset. I mean, we are human beings, and the tendency when someone makes you angry is to kind of lash out. But we have to remember, we're in positions of some control over the patient's life. And that is a very kind of stressful relationship sometimes for the patient, especially if they don't feel like they're being heard. Ty gave you some perfect examples of when, he felt disrespected and, was not being listened to. And so that leads people to feel, as he said, some kind of way, and really anger that can be avoided just because, we have some power. Do you use your power for the care of your patients, for the management of your patients, for their good, or do you use it, as just some means of control? So, setting the tone of what is said and how patients are spoken of in your clinic, starting at the top. How you address a patient, I refer to every patient by Mr. or Ms. So-and-so. Just if they, want to go to first names, that's okay. But we're going to start off and let them know that I respect them. The second thing I have, and I think it seems so simple, the words, treat people like you want to be treated. It always sounds like a simple thing, but I ask you, is your patient having the same experience under your care that you have under your physician's care? I have never had my doctor tell me that I have to do something. We have negotiated, working together on my care, but that word is kind of hard to, and it's come up a couple of times in the discussion. I tell somebody, I was raised with the phrase, I don't have to do anything but stay black and die, and it was funny. One of someone that I'm close to told me that her dad used to say that I don't have to do anything but pay taxes and die. So we all have kind of the same, um, the same verbiage that we use, but, it's important when you're sitting with a patient to ask yourself, are you setting the tone for the people who are underneath you, especially if you are a head nurse and in responsible for training the next generation of providers. I heard some things as a medical student that I was sometimes uncomfortable with. I felt powerless to say anything. I just compensated by going behind the people who are over me and showing, excessive amounts of respect to the individuals that I felt had been disrespected. But I'm gonna I'm gonna stop here, and speaking to the ones who are in kind of on the providing end, and I'm gonna pass off to Ty to give his thoughts on what you can do from the patient perspective to make things better.
Okay, so in my opinion, coming from when I was a patient, um, biggest thing that bothered me was the lack of explanation. I probably could have gotten past all of the stigma, the whole angry black man thing. Probably would have, because in the beginning it wasn't. I didn't feel like it was a negative thing. I felt like as more people picked up on it, it began to be negative because the ones that the staff that didn't really particularly want to deal with me, they took that name and they ran with it. So in the beginning, it wasn't a bad thing. It just trickled. But for me, the lack of explanation, especially, and I used that, I used when I went blind in my eye, because that was a very, 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 very tough time for me. And no explanation whatsoever made it even more tough. Um, so going forward, I feel like there needs to be just that communication between the patient and the staff and whoever's going to be dealing with that patient the most, just a sit down conversation and letting that patient know that you're in safe hands. Anything that I can explain to you, I'm going to explain to the best of my ability, but know that you are in safe hands. That whatever I can do to make you feel comfortable, I'm going to do. And it's not so much as babysitting or walking or holding my hand through the situation. It's just making sure that I am not in a position where I don't know what's going on with my body and you're not telling me what's going on with my body when that's what you're here for. Going forward again, the things like angry black man, let's leave that alone. I mean, don't don't label me that because I'm hurt, I'm scared. Pick my brain, talk to me. Then you might know that the reason why I walk with a frown on my face or the reason why I walk with my head and I'm looking down all the time is because I don't know what's going on around me. I don't know what's going on in my body. So don't just equate that with me being angry because of the look on my face. Pick my brain. I feel like there just needs to be more respect. You can call me Mr. Thomas all day long, but at the end of the day, your actions will make me feel like just another patient and not a person. So yeah, you calling me Mr. Thomas, but that's not. If you're calling me Mr. Thomas to my face and you're talking about Ty behind his back, then where's the respect? So all in all, we just need to make some changes just to make this thing great. And the thing is, it's possible. It can be done with just a little bit of effort. You just got to commit to the change.
Oh, and so I'm sorry. And now I'm going to pass it over to Sheila, who is our expert, and she'll take it from there.
Can you hear me now?
Yes, ma'am.
As we can.
Okay, good. Thank you so much, Ty, for that nice introduction. So my name is Sheila Davis Jackson. I'm in San Francisco at the San Francisco General Hospital Tuberculosis Clinic. And I'll share concerns our African American TB patients have shared with me. Let me start with some of the reasons I've been asked to speak with the patient. The patient might be presenting in the clinic with anxiety, anger, a non-happy attitude, distrust, disbelief, maybe just plain scared. So I proceed to meet with the patient and I introduce myself. Hi, I'm Sheila and I work here at TB Clinic. And I ask, how does the patient want to be addressed? You know, sir, madam, we all do that. It's the first thing we do when we meet a patient. I'm trying to make sure the patient feels as comfortable as they can by offering them water and a comfortable chair as we talk. I have the water with me. Our clinic building is an old school style brick building like you'd see in a scary movie and could contribute to their anxiety. I explained that I want to talk with the patient about what's going to go on with their care here at the clinic today. My icebreaker question to them is, how are you feeling today? Listening closely to the reply, which may or may not tell me something that's bothering them. But if they say, I don't understand what's happening, why I'm here, I want to go home, I really don't feel well. These are all familiar issues, and I have a place to start. But there could be many other reasons too. I'll tackle their concerns and questions one by one and asking, what exactly don't you understand? Tell me, and I can tell you what you need to know so you'll understand. Sometimes they share they don't understand why their symptoms don't go away or are worried they won't get better. Explaining first why they're here today. Well, right now, I know you aren't feeling well. And to answer your questions, you're here so we can further take care of you by starting you on medicines that will help you feel like yourself again, make you feel better, and cure this TB disease you have. That means no more cough, fever, night sweats, chills, feeling just really, really bad. There's a light at the end of the tunnel. We're here to help. Explaining further that I understand that you want to go home. However, by going home without getting the help you need to fight this TB disease could be fatal for you. I'm sure that you don't want to infect people you care about, like family and close friends, by being around them while you're sick. And we're going to help you not do that. Promise. I'll be honest, empathetic, transparent, and patient. Helpful, supportive, encouraging with some education thrown in regarding their specific TB diagnosis. I'll listen. And by listening, I'll build a bridge to improving TB care for African American people. If necessary, I'll de-escalate because TB illness isn't a priority for the patient. I'll explain why. Remember when I mentioned how the patient may have presented to the clinic anxious, angry, a bad attitude, distrustful, disbelief, and just plain scared? Well, here's part of the reason. Take a look at the slide on the screen. You see equality and equity. The slide is part of the reason why the African American patient may feel this way. The slide doesn't tease out the reason the patient feels the way they do. However, as I share more conversations I've had with African American patients, the slide, I hope, will become clearer. African Americans know all things are not equitable or equal for them. Trust, respect in the healthcare system is not held highly by African Americans. We've seen the difference in the healthcare for white people, fair, impartial, and the healthcare for African Americans, not fair, not impartial. African American people have experienced inequality and inequity for centuries. Equality is the state of being equal, especially in status, rights, and opportunities. Equity is the quality of being fair, just, impartial. These are unpredictable for African Americans. Most of us know that there is an enormous amount of work, education, messaging, and the right kind of mentoring that has to take place for equity or even equality to happen. However, as long as there's structural racism, vulnerable population, social determinants, and African American indigenous people of color, this work will continue to be a very, very uphill battle. These are some of the reasons African American people may present with anxiety, anger, a non-happy attitude, distrust, and disbelief when at the TB clinic or any clinic. They've heard rumors, Tuskegee experiment, and seen with their own eyes how African American people are treated in the system, the healthcare system. Institutional racism is real in the healthcare system too. Structural institutional racism, treatment biases, how the patient is treated as a person, an individual, as well as how they're diagnosed, whatever that may be, is going to affect their health care. Conscious or unconscious bias, deliberate or not, is felt by the patient. The institutionalization, mistreatment, disparity in the care for African American people has been passed down from privileged generation to generation since time immemorial. Keeping in mind all things are not equal for African Americans, no matter your socioeconomic status. Keep on looking at the equality and the equity slide. This is where the demoralizing, dismissive treatment has historically kept African American folks from early treatment. This is why African American folks present so sick. When I ask why it took them so long to come in to be seen, the replies vary. However, health insurance is a worry. How will this clinic visit and medicine be paid for? Possible child care issues too. They'll share how they've been in waiting rooms with relatives and friends before, and they've seen with their own eyes how long people have to wait to be seen, and they would prefer to wait the waiting game out. Translation: waiting for long periods of time to be seen while feeling sick, also while being racially profiled or treated as inferior, or even less than another human being, gives them pause to think. Waiting for long periods of time at a clinic in an uncomfortable chair in a hot or cold waiting room is a turnoff. Other everyday concerns and worries are on their mind. Perhaps young children they're responsible for, possibly missing a window of time to sign in for a bed at a shelter, or missing lunch at a local soup kitchen or a food pantry, or maybe just worried about their job. When they ask how long they will be in the clinic, I have to tell them the truth. I have to. Transparency. I explain that it may take a while because we don't want to miss anything. We're trying to be as thorough as possible and cross every T and dot every I to make sure we don't miss anything. I offer a cup of soup and juice in case they're hungry at this time. If they need to get in touch with anyone, I offer the telephone and step out of the room to give them privacy. Waiting for a long time to see a doctor is also a turnoff and makes people anxious and angry. Patients don't want to be made to feel as if they don't matter. We, TB Clinic, are inserting ourselves into their life. TB disease and TB Clinic has turned their life upside down. So many things are going through their mind. Now they have TB on top of everything else happening in their life. I hear them, and I'll gently ask about housing issues, Could they be couch surfing? How about legal issues? Do you have a court date? Where are you working, or are you working? Do you have young children or school-age children you're responsible for? Are you using drugs or alcohol? Do you have any other underlying health conditions, any mental health issues we should know about? If yes to any of the above, I'll share with them and the team to problem solve so that we're all on the same page with the patient. Sometimes they may share with someone else a different issue, like friends, relatives, finding out that they have TB. Sometimes we forget that TB has a long-standing stigma attached to it. The patient wants to know how long is TB disease and TB clinic going to be in their life? How is this treatment going to be paid for? I'm happy to share with the patient that this is all confidential care. We don't share their name or diagnosis. We are a no fee-for-service clinic. They aren't responsible for a bill or for the cost of their medicine, and will be out of their life as soon as they successfully complete their TB treatment. My hope is to be impactful, which leads me to ask at this point in our conversation, will you need a bus pass, bus tokens, or even a ride to the clinic for your appointments? Offering incentives, enablers, keeps a close connection to our patients during sometimes very long TB treatments. Gift cards for groceries or personal needs items from a drugstore are one less thing to worry about from a patient. As I close our conversation for now, I'll give them telephone numbers to the clinic, me, their case manager, their health worker, who will see them daily. Hopefully at this point in our conversation, I'm received as a positive, establishing a foundation of open communication regarding their health care with us, building a bridge to their TB care. Maybe we can make a positive impact in an African American patient's life. We can be the one place they can say that they felt like they were heard, seen, cared for, and looked after in a manner that felt respectful to them. That's my goal. Our goal at the TB clinic, to get our patients through their TB treatment and back to their normal everyday self and their life. Thank you all for listening. I'm going to pass it on to Rashonda. Thank you.
Okay, thanks, Sheila. So I'm going to go ahead and start sharing my slides. Okay, so I'm just going to introduce myself really quickly. My name is Rashonda Booker. I am the training and education developer here at Heartland. So for my talk, I just want to, after hearing different approaches that could be taken from Sheila, I just want to talk a little bit about the effects that stigmatizing language can have on healthcare. Before I jump into it, I just want to start off with the definition of stigma. Stigma is defined as a mark of disgrace that sets a person apart from others. When a person is labeled and stereotyped by their illness, they can feel less of a person or less of themselves. This derogatory labeling and negative beliefs can create prejudgment and discrimination towards others. So many people wonder how stigma affects TB care. The truth is, stigma have major impacts on the type of healthcare one receives from professionals, as well as the kind of healthcare they seek for themselves. Stigma can alter the perception of individuals and in turn cause healthcare providers to provide less than quality care. In the past, there have been individuals who have reported that fear of being stigmatized has altered their willingness to undergo TB screening and seek medical care after the onset of symptoms. This fear can then put a delay on the TB diagnosis and can negatively impact treatment compliance and completion. Words do matter. Choosing them wisely is very important in patient care. Poor choice of words can have a bigger influence than we may think on the patient's decision to seek treatment and continue treatment. We should all be sure to select proper terms and phrases when caring for patients. We never want to make them feel like they are at fault, being criminalized or forced to do anything. So there are 4 major terms that we really like to focus on, which are TB case, defaulter, suspect, and control. These words can cause a negative healthcare outcome or cause patients to completely neglect their healthcare concerns altogether. The word defaulter. So first, if you look at the screen, they're all listed on screen right now. The word defaulter can be replaced with person lost to follow up. The word or phrase TB suspect can be replaced with person to be evaluated for TB. TB control can be replaced with TB prevention and care. And TB case can be replaced with person with TB disease. To get more information on alternative terms or phrases that can be used when caring for patients with TB, Heartland does provide a product, a stigma product that you can find on our website. It can be printed or it can be downloaded and saved on your computer. It can even be shown at a patient visit, just to show them what should be used and should not be used. And I do have the Heartland website link on screen right now, and if anybody wanted to visit the website for this product. And I will now hand it back over to Dr. Armitage. Thank you.
So I wanted to first thank our panel here for, offering up some thoughts on things that, we might try and things that may work, because really when it gets down to it, we are public health, we are healthcare providers. And I think there would not be one person signed on to this webinar that wants to know that they make their patient feel, badly. And so I love, Sheila's challenge, to go out there and make your patient feel like this is the one place where they get respect, one place where they feel, cared for and respected and taken care of. So I'd like to throw that challenge out there and hand it back over to Kay for our exercise.
Thank you, Lisa Armitage. And thank you to all of our panelists. I'm Kay Wallace, a program manager at the Curry Center. And during the panel presentation, we posted a few questions in the chat section, and we thank participants for your thoughtful responses to those questions. What we'd like to do for the next few minutes is to explore a few of those questions with our panelists. So panelists, please all take your mute off if it's on right now, and we'll get some additional insights on some of those questions. So let's go back to this issue, this critical issue of respect. And Ty talked about not always feeling respected as a TB patient. So let's talk a little more specifically about how you demonstrate respect to your patients.
I think, for me, just very important, as the physician walking into the room, to address them, by their, by their title. Again, it's like, it's, sir or madam, but sitting down at the level of the patient so that we are eye to eye and I'm not standing over them, just basic doctor skills, looking them in the eye and hearing what they have to say. I don't care what it is that they're telling me and how trivial it might seem. If their left toenail is slightly longer than their right toenail and that is really bothering them, then we're going to have a discussion about that toenail. But just listening to the patient and not belittling anything that they have to say. Never with my tone implying that what they say, you should know that. Like never questioning, they're always, it's like I said, it's doctoring 101, but I think sometimes we get in a hurry and we forget to show that respect.
Mhm. Thank you.
So this is Sheila. So I think Lisa hit it right on the nail on top of the head. You have to listen to the patient. You have to come in with a respectful attitude. How should I address you? Sit down and talk with them and not rush. You really do have to take your time because if you want the patient to be comfortable and share with you, they have to feel that you're present in the moment.
And I also feel like we need to at least make a connection. Now, again, I appreciate the Mr. Thomas. That's great. I felt like if somebody would have got to know me as Ty, then the process would have been a lot better because there is a lot of layers to Ty. You know me as Mr. Thomas, but you don't know Ty. Mr. Thomas is the patient. Ty is the person. So I get the formalities, Mr. and Mrs., but sometimes you just gotta get in there and learn this person's first name and make it more personable.
Mhm. And one of our participants made a great comment too in the chat section about nowadays not assuming any particular pronoun or gender and just asking the question, how would you like to be addressed? I'd like to move on to a couple of things that both Sheila and Lamisha touched on, and that is that we're dealing with a context in which there has been historical, either lived experience or historical trauma for the African American community. And that can certainly lead to another topic we hear about a lot, especially in the realm of COVID and vaccination, which is hesitancy. So the patient who is either hesitant or distrustful of their public health provider, their medical provider, and how specifically do you address the issue of hesitancy?
I think you just go ahead and ask the question. You speak to the patient and say, I don't think or I'm not feeling that we're on the same page. How can I reassure you? How can I make you feel more comfortable with our discussion, our conversation about your health? I just want to help. Basically, you just put it out there. You just lay it out there on the table and let them kind of take it all in and make their decision about you. So it may not be that day. It may be somewhere down the line, but at least you've put it out there and that they know where you're coming from and how you want to try to help them get through this TB process.
Yeah,
I'm sorry. I want to follow up because when Sheila was saying, it brought me back to a time where my initial doctor, Dr. Vasquez, she had went on vacation. And it was in the beginning of the process, so it was still difficult. And Dr. O'Neill, and I just want to give him just a little bit of praise because he came in a situation where I was just totally confused. And he actually, I know he had a long laundry list of things to do that day, but Dr. O'Neill sat in my room for about an hour. And he explained things to where I knew at that moment I was going to be okay. This was just a period of time that I had to go through in order to get to that point of okayness. And I appreciated that. And I think about him often when I see him on TCID grounds. I always make it my business to, even if he's clear, hey, Mr. O'Neill, that's just me. Because I need him to know that I appreciate that moment where he just made everything okay. And of course, things got, it was just a scale. Things got bad and at the end, and then it got good and bad and good, but that particular moment. So there needs to be more Dr. O'Neills in this situation. That's just my personal thing.
All right. I think for the sake of time, Lisa Chen, I think we're going to turn it over to you to introduce our next activity.
Well, just go ahead and share this slide, Jeannie. And we're just going to take a quick 8 minutes. And we want you to have a chance to just open up and speak to some folks who you don't know until now. We're going to go into breakout rooms for about 8 minutes. And I want you to, you know, jump into these rooms, turn on your video. You know, remember, it's a safe space to share your ideas on what's the one thing I'd like to do in the next 2 weeks, to think about what I can do in my life, you know, my professional and personal life, but particularly professional, to improve the TB care for African-American patients. I want you to know that this, you know, everyone should treat this as a confidential session, that you're not going to, you know, take these ideas, you're not going to share who said what, but hopefully you'll share some great ideas that you may glean from talking to your peers, and just, you know, make a safe and supportive space for us to just talk out loud, you know, to grow a bit. So be ready to jump into rooms. We're going to be there for 8 quick minutes, and we'll see you back here. Have fun. Folks, I think everyone should be coming back now. We're almost all there, I'm thinking. So I'm looking to see if we've got everyone back. Thanks, folks, for, you know, for many of you who turned on your videos in these shared groups. It was just good, probably, I don't know, it was helpful for me to see some faces, some familiar faces too, that just to keep this conversation going, to start the conversation and keep it going. And I just want to just take a minute and just ask people, so you just had a chance to talk to, you know, 4 or 5 new best friends. And so just go ahead and throw in chat any good ideas or main themes that you heard, because I think we're all grasping for actions, like things we can actually do now. We feel such strong emotions, and we all want to do something in our lives. So, and I just want to pause and look to the faculty from this talk. You were all just in rooms too. Did you hear anything that just you want to share? Go ahead and unmute yourself, faculty. And I'm looking in the chat.
So, first of all, I'm here in Texas, and the weather is atrocious, and I was paired up with Deborah in Hawaii, but I'm going to call her out, but she's like looking out at the ocean. I'm a little jealous, but she had, you know, she brought up one of the points that I think sometimes we don't think of. Like, for me personally, I was just saying it's you have to be a certain kind of brave to go walk up to somebody who doesn't look like you and engage them, you know. So, but, you know, one of the points that she made is, you know, letting people know that they're not the only one, so they don't feel like they're the only person, you know, in the world that has what they have. But when you ask people, the point that I took from that you made, you like, how many times a day do you pass by somebody and say, hey, you know, how you doing, how's it going? But to stop when they tell you, you know, they're going through it, or they're not, you know, they're just like, all right, but not great, to stop and listen to what they have to say, and, you know, hear them at that point. And I think it's, like I said, it seems like that's just kind of the simplest thing, but we don't, you know, how often do we do that?
Yeah.
That's the best nugget I got, besides the fact that she's looking out at the ocean.
Well, I appreciate that. And there are folks saying things like, just go in the room and look up from the forms and look at the face and the eyes of the patient that you're talking to. I love that. And Sheila, she heard, be genuine. Mm-hmm. You know, be yourself, and try to find out who the person is that you're talking to and what their fears are, right? Anybody else? want to just chime up with something good they heard? Ty, Rashonda, Sheila?
I was talking to Kay and Lynette from one of the participants. And again, Lynette, thank you for your words. And it's something that I had a meeting not too long ago with one of the caseworkers here at TCID, and we was just bouncing around ideas. And I think that an orientation period or some way to build a foundation in the beginning is important. It's like a relationship. You want to go in the relationship knowing everything that you can about the person that you're about to date. So why not have a period where you and your doctor and maybe a staff member or two in the room, just bouncing off ideas. You don't necessarily have to be talking about TB. You can just be talking about life, period. But you're building a foundation and you're communicating. And that way, when things get tough down the road, you know you can run back to your foundation because your foundation is built. So, and I'm sorry, I get passionate about this, but it's simple. If we just commit to doing the things that we need to do to make it okay, it's simple. It's going to be a journey, but that journey is so simple. Let me stop because I'm rambling, but it's simple. It's simple, guys. It is.
I love your words, Ty. I think everyone, you've seen all the love coming at you in the chat throughout the hour and appreciate it. And I want to be respectful of everyone's time. We're running a little bit over, but I do hope everyone can stick on for a minute because I found Lamisha's narrative, just always it's just useful. I take it to heart. And I want her to have a chance to give some just last thoughts before we sign off from this meeting. Lamisha? If you want to unmute yourself. Yeah.
Oh, all right. Thank you so much. So, one of the most important themes is really the spirit of allyship. And I think as healthcare workers and folks that are givers, right, there's the assumption that we're constantly in the spirit of giving. But there's an opportunity to really examine the things that we move towards and what we give authentically to, and the times and the moments where we hold back. And maybe that's because we need to balance and hold our own needs for self-care as well, but it's not always equitable. And so the spirit of allyship is an opportunity to examine the places where we can be in greater alignment and greater solidarity to others. And I just want to leave you all with just a couple of thoughts in terms of like a charge, right? So part of it is the opportunity and the invitation in the spirit of cultural humility to really learn more about the history of healthcare inequality. It's amazing that our trainees and emerging healthcare professionals actually do not have, and they're not taught, sort of the legacy and the history of where healthcare in America really comes from, and all the problematic things that have occurred in the past that continue to resonate in today. And the other piece is just about examining your own biases. We all have work to do. So identify opportunities to amplify your growth journey around equity and inclusion. Be a better colleague, and really think about the ways that we can examine the gaps between your aspirational values for being equitable and really how that's showing up in behaviors, right? And then finally, for folks, particularly those that are in leadership and managerial positions, beyond just hearts and minds, we also have to examine the ways in which our policies and our practices work well for some, but do not work for others. So really from an equity lens, pivot back to and center those who are most impacted, who are most marginalized, who are most left out of our resources, and center them when you're designing your next initiative, your next outreach, or your next policy, whether it's about how we greet our patients or how we sort of prioritize care. And so with that, I just want to say thank you all.
Great. Well, thanks. And I know there are questions. I wish this could go on for a while, and I know that we're already running over, but I do want to thank you, Lamisha. It really is, we've got to show up. We've got to show up. And so I know there's a lot of leadership across the country who are on this webinar right now. I want you to take those words to heart. And there's a lot of us who are on the front lines, and we see people every day. And I just want you to kind of dig deep and think, can I show up? Lisa, any last words?
I think that pretty much summed it up. I want to thank each one of the people who presented today, Lamisha, Rashonda, Sheila, Ty, and my other Lisa and Kay for, and specifically I want to give some kudos to Janie for cat herding all of us together from all the different places that we are. But I'm just so grateful for the people who participated in presenting this and bringing it to the folks who are on the line. But thank you to the folks who came to share with us and participate today.
All right, run off, enjoy your day, you guys. Look at the resource materials. We Are TB is a fabulous group Ty's a part of. Look at their resource materials. Thanks all. Take care.